Hello and good afternoon. It's great to be here. It feels familiar. It seems like only a week ago that I was on stage in Manchester making a speech about the biggest hospital building programme in a generation, which I don't know if any of you heard of it. We made some progress. Well, if you didn't, one of the highlights was my trip to the North Manchester General. Anybody here from North Manchester? Excellent. And I went there with the Prime Minister, and we went as part of the announcement of the 40 new hospitals that we're building over the next decade. And we met with Raj, the Chief Executive, and his brilliant senior leadership team. And actually, we met with some of the patients being cared for by the brilliant staff. As we were looking around, it became abundantly clear that those facilities, which were built in 1876, aren't the facilities for a modern NHS. Within that building, there were staff doing brilliant things. There were nurses giving great care. It's amazing when you go to a hospital with Boris Johnson, everybody wants a selfie. There were people doing incredible work. But one of the members of staff, a doctor, said that working and delivering care in that setting is like asking a Premiership footballer to play on a ploughed field. And I thought that was incredibly telling. All I can say is it's a good job that Solskjaer isn't running an NHS trust. As a Newcastle United fan, after last weekend, I think Manchester United will be in special measures by now. But poor facilities are not something that we should have to accept and that you should have to accept for your teams. And the right leadership is so important to the health of the NHS. I know that's been something that you've been talking about at this conference, and it's something that Dido Harding is so focused on. What's more important too is that our NHS leaders need to have the right support, that you're not trying to operate with one arm tied behind your back. And as Health Secretary, I've tried to spend as much time as possible listening to you about the support that you need to do your jobs and backing the leadership of the NHS right across the country. And what I've seen is that the best chief execs and the best run trusts, they all talk to me about their long-term plan for their trust, for their hospitals. Now, of course, we all face short-term challenges, day-to-day pressures. By God, in my line of work, I know that. But good leadership is about being able to look ahead. It's about being able to anticipate and plan and to think beyond the next season and to think about the resources and the changes and the innovation that you're going to need over the years to come. One of the most pressing demands is, of course, for more people. I get that. And that, of course, is what most of the 33.9 billion extra funding for day-to-day expenditure will be spent on, people. Around 70% of the current budget of the NHS is spent on people, and that will be what the majority of the uplift is, in the end, spent on. And there'll be much more on that in the people plan that'll be published later this year. But today I wanted just to talk about three other things that are going to be integral to the future of every NHS trust: the long-term plan, capital, and technology. And I'd just like to take a moment, if you'll forgive me, to focus on each one. First, it's worth saying a word about the long-term plan bill. Simon Stevens and his team have consulted right across the NHS with colleagues across the country to develop proposals collaboratively for a long-term plan bill. We want any legislative changes to have widespread support and to ensure that they help speed up the delivery of the plan. At their heart, the proposals, which I'm considering carefully, will empower you to work collaboratively with other providers and commissioners to reduce bureaucracy and procurement costs, so we can improve care and get the very best possible return for taxpayers. The proposals set out how the NHS is moving from competition to collaboration as the main driver for service improvement. I am a huge fan of the concept of continuous improvement, the need to break down each process into its constituent parts, understand how we can improve each one of those parts, listen to the people who actually do the job, and just keep improving. Try, see what works, and iterate. And this is the case when it comes to joint working in particular, where I want to remove a whole load of the barriers. Choice for parents, yes, that must remain, but choice for patients, that must remain. And competition should be encouraged where it can lead to better outcomes. But it doesn't have to be done in a bureaucratic, crass way. It isn't the organising principle for the NHS. So, for instance, on mergers, trusts need to be able to take merger decisions in the best interests of patients, and patient interests should be clearly defined. Fine. But the Competition and Markets Authority merger review process adds an unnecessary layer of bureaucracy that is time-consuming and costly and has knock-on effects for staff and patients. So the proposals recognise that while the CMA has an important public interest role to play when it comes to things like pharmaceutical pricing, proposed trust mergers are better assessed by the NHS. After all, trusts are public organisations, and the CMA is there to make sure that markets are competitive. So let's make those decisions within the NHS. They're better placed because quality of care and the best use of NHS resources should be the guiding principles when it comes to deciding on mergers, tariff setting, and licence conditions. And on tariffs, the long-term plan sets out how we're moving away from activity-based payments to population-based payments. Why? I have endlessly been told about the perverse incentives that are implied in the activity-based tick-at-the-turnstile pricing and tariff mechanisms. We need more flexibility to spur innovation and to remove these perverse incentives. We're already doing it with blended payments for emergency care and multi-year tariff setting, but we can go much, much further, and we will. Fair, transparent, locally set prices will make it easier to redesign care across providers, support preventative care models, and reduce transaction costs. And then on procurement, you know more than I do. There are too many complexities and costs with little added value for patients in return. So we hear what you're telling us, and it's clear. We need simpler, more refined procurement that reduces bureaucracy when you're developing competitive tender bids, that makes it easier for you to work with commissioners to develop innovative clinical models. And this procurement model should cover commissioning of all healthcare services, not just arrangements with NHS statutory providers. So we hear you, the voices of the NHS. The second thing I want to talk about is about capital. As I mentioned at the start, last week here in Manchester, we launched the Health Infrastructure Plan. It's the biggest and boldest hospital building programme in a generation, properly funded, not through painful PFI deals, and properly planned so the NHS is ready for the 2020s and beyond. Now, you all know the top-line figures, and some of these caused a little controversy when I announced them. 6 new hospitals that are ready to go and will start immediately, and another 34 in the pipeline that have been given the green light and given the seed funding to develop their plans further. One of the criticisms of the programme in the past has been that there hasn't been that long-term approach, and instead there's been a constant demand for projects that can be funded immediately if we can get the funding out of the door in the next year or two. Instead, we want to develop the pipeline of projects. But the Health Infrastructure Plan isn't just about building new hospitals. It's about capital to modernise diagnostics and technology, modernise our primary care and mental health buildings, and help address critical safety issues that I know that many of you face. It's about the capital system as a whole. Now, you know better than anyone the challenges that we face. That capital allocations have been too stop-start, the disjoint between the national allocation and the local decisions, and the last-minute nature of some approvals. This new regime will provide indicative multi-year planning envelopes that'll be then confirmed annually. To balance control and delivery, we're proposing two sets of changes. One, to offer more assistance to providers in developing their business cases, and two, to streamline the approvals process at our end. To ensure that funding reaches the front line as soon and as efficiently as possible, all national organisations will need to work together more and work more closely to manage NHS capital expenditure through greater budget transparency and improved forecasting. Under this new system, providers will remain responsible for maintaining their estates and for setting and delivering their organisation's capital investment plans. But local providers have got to work much more collaboratively to plan capital investment too. After all, as we discovered this summer, if one trust breaches capital spending limits, then clearly that has a knock-on effect on others and on their capital plans because we all share the same national pot. ICSs will have primary responsibility for spending within their capital envelopes, covering both types of acute trusts, mental health trusts, community trusts, primary care, and of course linking in with ambulance and specialist trusts. I want to see much more capital and estates collaboration through ICSs. I want to see providers who think that they can use local assets currently owned by NHS Property Services to take over those assets and use them for the very best of their local health systems. We've seen some early examples of the use of this new power that trusts have got to request ownership of NHSPS assets, starting in my own patch with Newmarket Hospital. And I will be open in principle to all such transfers within the accommodative rules that we've set out. Trusts need to think of their physical assets as working for the system, working for the ICS. And ICSs need to work to make the most of the assets they have locally. And everyone needs to focus on using our physical assets to bolster the most important asset, which is the health of the population who we serve. This is the new vision, and I need you to help me make it a reality. The role of regions will be advisory, to support ICSs with advice to deliver on their plans, to ensure ICSs in turn work with each other, and to make the relationship between the centre and the local systems tractable. And then we need more integration at a national level too. In a way, this is my bit. There will be one capital sign-off nationally, a capital committee, including NHS, E&I, and the department. I want the national sign-off to be spectacularly more straightforward. We will be the guardians of national capital expenditure limits and strategic in allocations of central capital and encourage planning for the future through the HIP process. But I have heard you loud and clear when you say that the bureaucracy around sign-offs needs to be radically simplified, and it will. The system needs to be fair for everyone, NHS trusts and foundation trusts alike. We want to make sure capital better flows to where it's most urgently needed, while still rewarding trusts for strong financial performance and preserving the autonomy trusts have, while ensuring that the whole system uses capital as strategically as possible. All of this is with the aim of building a more equitable, fairer system, where every constituent part of the NHS lives up to its responsibilities by acting in a more collaborative way, and that collectively we all act in the best interests of patients and taxpayers. And I just want to say a word about what I really mean by integration too. This isn't superficial. I want trusts to be bold when it comes to integration. It's very easy to point at real or perceived barriers and say, let's just do the bare minimum. primary care, community care, mental health, adult social care, they should all be looking at ways, including structural ways, in which they can properly integrate to provide a more seamless experience for the patient. Engaging and inspiring the workforce, of course, is critical to achieving this, and empowering the frontline staff to own the integration and find themselves all the myriad ways to break down barriers and make things work better. And that, of course, means, in turn, investment in the wider health and care infrastructure, because I appreciate that the capital plans that we've set out and what we've talked about so far has started from the point of view of the acute providers. But the wider health and care infrastructure, at the research end in genomics, at the community and public health end in prevention, in terms of collaboration with industry and the life sciences, the wraparound care and support that we provide to elderly people and people with physical and learning disabilities, the whole of the NHS is moving towards system-level working, and it must. And you are vital leaders in that system. And that brings me to the final point I wanted to make. It's hard to make a speech like this without mentioning technology, not only because it's something I care about and it's something I understand, but it's because it is important to knitting this whole piece together. I'd like to think that since last year's conference, we've got to know each other a little bit. I've made my case for the power of technology passionately and repeatedly, and to give a lot of people in this room a lot of credit, there's been a great response. So across the system, we're axing the facts and purging the pager, and I've set up NHSX to drive digitization across the whole health and social care landscape. And the team at NHSX is getting the right architecture in place, common standards on, for instance, privacy and encryption and interoperability and data, not just the right technical architecture, but shared standards on governance and procurement and contract, so that you can buy whatever you want from whoever you want, so long as it's safe and interoperable and meets the standards and does the job. This standards-led approach, open to innovation from outside the NHS, is the only way to go for an organisation as large and complex as the NHS. It's already starting to bear fruit. Just under a third of the population are now registered for a GP online service. That is more than 16 million people. By the end of this year, every member of staff, for instance, at Imperial and Chelsea and Westminster, will be using a single shared electronic patient record system. Around 17,000 will have only one EPR to learn, and patient records are going to be available both across the organisational boundaries and appropriately to patients themselves when they want it. The point about the approach that we're taking to technology is that we trust you to do the job that you do. So we're going to mandate these tech standards for providers, like we've done for GPs. We don't want to micromanage the decisions, the purchases, and the technology that you use, but rather empower you to make the right decisions for your communities and the care that they need, but fitting within the standards so that everyone's system can talk to each other. Now, the truth is that getting the right architecture in place and mandating these shared standards isn't going to be enough. It's also about cold, hard cash. So let me say this loud and clear. For me, this technology is not about getting the latest gadgets and gizmos into the NHS. That's often exciting. It's often what people focus on. It's actually, at its heart, about ensuring that we upgrade the slow, outdated, and often dangerous systems so we can save lives and save time for staff. I've seen it right across the NHS working well. I've seen it in Salford. I've seen it in Addenbrooke's. It's happening in Birmingham, in Southampton. These are trusts that are investing in the right technology to support their staff and make their patients' experience better through that investment in technology. The driving force needs to be meeting a set of core digital capabilities, but of course, without the necessary spend, that's impossible. How can we unleash the potential for our national NHS AI lab if hospitals are still printing off x-rays and sending them by courier to be analysed. So we need the right architecture and standards and the right culture of innovation and the right level of tech spend. And this is about seizing the once-in-a-generation opportunity. The record 33.9 billion we're putting into the NHS offers us the chance to build a health service that is truly fit for the future. And then with the multi-year capital budgets to be set at the next capital review, we can land that side of the equation too. So this is what I have to offer: a long-term plan that looks to the next decade and beyond, a health infrastructure plan that takes a more strategic approach to capital, and a new technology priority, properly mandated and properly funded across the NHS to save lives and save time for clinicians. That's how I plan to ensure you get the right support to do your jobs, so that you can build up your organizations, so that you can back your teams and the leadership at every level, so you can lead with confidence and optimism about the future. That's how together we can build an NHS that's there for every single member of our society, for generations to come, whoever they are and wherever they live. Thank you very much.